Testosterone-Deca, Deca-Durabolin, gene effect. Could this be you? Welcome, my friend Zach MacDonald, PhD student, University of Connecticut. This is a bright man here, and he's allowing us to present this amazing information for the incredible effects of testosterone, not to mention other anabolics, on red blood cells, hemoglobin, hematocrit, and iron studies with genes, hereditary hemochromatosis. And you guys follow me on this. We're going to make it very simple. We have some nice graphics. I have some information from a real top doctor who's a hematologist that Zach has gone through. This, again, is really a compilation of about a year's worth of data.
Yeah, I'd say that, yeah.
We're going to run this right here. Zach, thank you so much.
Of course.
Okay, so Zach's the patient. He's also a very smart man here. He's a student as well. Zach, what kind of student are you?
So it's my 4th year here as a PhD student here at University of Connecticut in the exercise physiology program in the kinesiology department. So basically studying how to get big is my living. So might as well make a career out of it, right?
Awesome. So let's get right into this. So essentially, we're looking at how a man like this that's been on testosterone, right, for years, he's on physiologic testosterone, he's not on steroids, I'm his doctor, he allows us to do this, for everyone to learn for education here. And for years, of course, he's on testosterone, doing well, and all I'm looking at is a CBC with hemoglobin and hematocrit. Now, I'm going to talk about some of this graph lines right here in a minute. And then Zach's allowing us to go into some of just the basic information. He adds a little Deca-Durabolin, right?
Yep.
Oh, just a little bit, and he stopped it. And again, he's a great guy. It's a great patient. He's a good man. And so, again, the effects of sundry effects of synergistic effects of androgens just on the hemoglobin, hematocrit, and other iron studies, okay, what this will do to you over your life. So many people ask, Doc, who doesn't love to add different steroids from time to time? And I'm watching everything, Doc. I do my research and watching hemoglobin, hematocrits, blood pressure, my ABCDs, right? A1C, blood pressure, cholesterol, heart, and all the stuff. And guys really think they're on top of this stuff. But if you're not looking at the details of the hematologic side of this stuff, which even myself, up until about 5 years ago, I was just looking at hemoglobins and hematocrits. And if I didn't see a problem, I wouldn't look into further information, listen to this stuff. So Zach is cruising right along on testosterone, doing very well. The red line is hematocrit. Now, we've used 2 scales here that I've normalized these scales for you guys, and we have a lot of information, but we summarized it, and Zach made this graph here. So this is hematocrit, you could see it's in red, but also the saturation is in blue. Look how high up that is, up to near 100%, and you could see this baseline is around 75 right here or so. But you see, I could tell you that the normal level for a saturation is 48 to 50% right here. That's that 50 right there. Now, it's a great reference point because his hematocrit is also running around 50, actually under 50, and the upper limit normal of a hematocrit is going to be 48, 50, even 54%. So that's why that 50 is normal, 48 to 50, 52% for both saturation and hematocrit. Right, Zach?
Yeah.
Okay. So Zach's running normally right here, and then he adds a little bit of Deca in, and then I see this. We stretched out this line, the X and the X-axis here, so it flattens it. But you see that pipe up? He went over 50%, and he's young, and I didn't start looking at this stuff, and then I thought, wait a minute, Zach, what's going on? Well, I threw a little Deca in. Boom, please stop the Deca. Let's go for some iron studies. Look at this. Again, these graphs, we had to kind of normalize them together. But you see, that's when I found out that this man, who otherwise stable, his A1C is perfect, his blood pressure, everything else, this man, he's just a super healthy young guy, 26 years old, right?
Yep.
Right. So young guy. So we see that underlying silently, he's running these saturations that are very, very high at baseline. Of course, the Deca pipes it up, and then it comes down. We did some phlebotomizing. This is from 2021 all the way here to 2022, over here into 2023. And so what happened to Zach is that I realized that there was something else going on underneath just being on testosterone. And then I'm thinking, when I'm looking at all this data over time, how many men are out there? And with the genes that these men have, we know Northern European ancestry, there's genes for something called hereditary hemochromatosis. Right, Zach? So,
yeah.
So Zach comes off, he's just on testosterone. Testosterone never goes over 400 to 700. He's on, what's your dose, Zach?
It's 100 milligrams every 6 days.
Not a big dose. And
no.
How much do you weigh?
170.
Okay. And this guy's, look at this fit guy. I mean, you're in great shape.
Nice compact 5'5", you know?
Right.
And a quarter.
But super healthy guy, right, Zach? And
yeah.
You feel good, and you love testosterone on the brain. And
no complaints, man.
We won't talk about the sex, but it's like, he's a great guy and super smart guy, and he's just an absolute sweetheart and a friend of mine. So when you look at this stuff, and I saw the saturations, I said, Zach, let's just go back on test. He did. Zach, saturation's still up. Now, ferritin, I'm going to go over this here in a little bit here from what the doc we sent him to. Ferritins are always low normal. So it's really something that I was like, oh, the ferritins are good. And I'm going to go into the deposition disease here in a minute and the real technical stuff here. And I thought, so that's good. He's never had DVTs. He has no family history of hereditary hemochromatosis.
No.
So nothing at all. Family history, super tight, young, healthy guy. Only thing I have in this guy is this baseline that pipes up with the added, with Deca NOR19 drug. Everyone knows when you add Deca or equipoise or any sundry good, strong anabolic over a period of time, you're going to see a bump up of the red cells, right? And then, but what's happening underneath with the iron studies? This is the silent stuff that can be certainly deadly. Deposition disease. You want to read about hereditary hemochromatosis underlying with deposition disease, where the iron can deposit your brain, your heart, and your liver. So he's running. Now over here, where we were phlebotomizing him, you could see we were lowering it down, but he never actually went down to around 48% where he should be. That's the 48%. The hemoglobins, look at that. Hemoglobin, as soon as he stopped the Deca, stayed on just a little test. We doing some phlebotomy here. Look at that. He was well under 50%. See that? Perfect right there. So, but he still was elevated on the saturation. And I can tell you his total iron levels were also elevated. But it's a different scale, XY axis. On the X, we want to leave that alone, right? This brilliant man put all these things together, and we came up with this great graph. And that's why I have to explain it, right, Zach?
Yeah.
So you understand this, right?
Of course.
Right. So that normalization, guys, the 48 to 50 is our kind of our baseline, right? And then we know that the representation for the saturations are look at that, it's well over it.
Yeah.
And how many men have this? Many. But with or without ferritin levels and with or without disease and deposition. So I send him to a board-certified hematology doctor, right. Dr. Todd Election, absolutely great guy, up in the Northeast, board-certified internal medicine and board-certified hematology doctor, one of the many doctors I work all over the country with. So we sent him to Dr. Election because I said, Zach, I really don't know what to do. Hemoglobin's perfect, hematocrit's perfect, ferritin's perfect, vital signs perfect, no DVTs, venous thromboembolisms, heart attack, stroke, calcium score. We didn't even do it because you're so young.
Yeah.
Did we do it yet? No.
I mean, at the time here, I was 24, 25.
He's 24 years old.
Yeah, so,
and he has no family history. Cholesterol is perfect. Blood pressure, not pre-diabetic, not diabetic. It's perfect. He doesn't need a calcium score. Of course, around 30, we're going to do it. Guys, I'm being honest. So yeah. I'm concerned just for right there. I'm concerned for this run of the iron levels that are just high and the saturation. But the ferritin is normal. always chronically, and so is the hemoglobin hematocrit normal. Here we go. Let me read you the note, right? Zach allows me to do this. So Zachary returns for the hematologic follow-up and to discuss his recent test results. Recall, I saw him on August 29, 2022. This was in the fall of 2022. His consultation to evaluate abnormal iron saturation from Dr. O'Connor. There was a reason to suspect that he may be a carrier of abnormal hemochromatosis gene. His history of elevated iron saturation with normal ferritin dates back to approximately March of 2021. And then, of course, we superimposed it up here. 2 separate occasions where iron saturation, 75%, ferritin 58 nanograms per milliliter. And then he talks about iron saturation goes all the way up to 97%. You see that, Zach? So you see those on...
That's our point here in August.
Those 2 equations, right? Those two pieces right here. And that's concerning. And then he talks about the hemoglobin's 15.9 grams per deciliter, hematocrit's 45.8%. If you just looked at that, guys, if you're at an anti-aging place, if you're at, I'm not going to put them down anymore, if you're in the streets, if you're doing it yourself, if you're in Australia, if you're anywhere in the world, UK, guys in Pakistan, anywhere in the world, South America, Central America, anywhere in America, anywhere in Canada, if you're not understanding this and you're young, you don't understand your iron studies, you're going to potentially be in trouble. I sent him to this doctor, and on August 30th, 2022, hereditary hemochromatosis DNA mutation analysis revealed 2 copies of H63D mutation. This is homozygote for hereditary hemochromatosis. Okay, so, and now he's talking about that he discussed the genotypes that affect 1% of the population. 1%. So let me read the rest of what he said, and then I'm going to interpret it for you guys, and Zach and I are going to talk a little with what I would recommend to anyone in the world that really is on androgens and wants to understand, not to mention adding Deca or equipoise or any drug or trend. So any drug, even Anavar, will have effect. So I have again discussed the iron metabolism in humans. I discussed the role of hereditary hemochromatosis, proteins and iron balance, and as well as different mutations resulting abnormal hereditary hemochromatosis proteins, genetic variations. Have discussed several mutations in hereditary hemochromatosis gene that have been identified, results are abnormal for him. Discussed the serum protein, iron levels, TIBC, role of ferritin, interpretation of ferritin, calculation of iron saturation. Then he says, he closes, he discussed the developing iron overload. That's the iron overload. When you see A, B, C, D, D is deposition. Are you going to deposit iron over time silently into your brain, your heart, and your liver right there? That's hereditary hemochromatosis. That's what it is. And again, he has the genes for it, and he's affecting it on androgen, just testosterone a little bit. In the end, we're going to see that what this doctor recommended, I'm getting right to that flashpoint, but when you add a little bit of androgen, like Deca, even a little bit lightly, look what...
Little does quite a bit.
Right, and if we didn't know that, but your saturations went way up, right? And then they actually piped up again here, and this is just from androgen itself, just testosterone. So we had no idea this was going on. So, and then there's going to be weight related, sleep apnea, high elevation, again, real genetics, and then getting older just seems to happen. But it's really going to be the effect of the androgen on your genes. So he talks about the iron overload for you, because I wanted to know about this. And he said that for you developing this is unusual, but there's no, because you have no clinical or biochemical evidence of iron overload. Ferritin, 58 and 88 nanograms per milliliter. Boom, ferritin is low, stored form. You've got to put this together, guys. It's unlikely that given his genotype that he will develop iron overload. However, he discussed that he should take all measures to minimize exogenous iron intake. So when doctors see low ferritin and they don't measure everything else, They're giving iron. You're phlebotomizing and then giving iron. Guys, this is the Dr. Election that said to me, you're driving the car, Tom, Dr. O'Connor, you guys are driving the car with the gas on and the brake. Gas, brake, gas, brake, gas, brake, gas, testosterone, androgens, phlebotomize, brake, brake, brake. Give iron tablets. My doctor says I need iron tablets. What are you doing? Gas, brake, gas, right?
I mean, I couldn't have put it any better myself. It's it's important to remember that things aren't affected in isolation. Everything happens in a cascade if you think about it. I mean, that's honestly a perfect way to put it in that metaphor, but it's like if you didn't look at these two things in concert, it's like you wouldn't have known really, but if you're just looking at this, you wouldn't have sent me to Dr. Election in the first place.
Right. So, okay, the bottom line is Dr. Election said he's okay. He said keep the androgens to a down low, right? Which you do. So, number one. Number two, don't take iron and keep your... He did say keep the iron dietary aspects to a down.
Yeah, so
now,
it was the...
Explain to us, and he said no alcohol or limited alcohol. What else did he tell us?
So coming from the diet aspect so essentially I really don't consume, much alcohol. I very seldomly drink even red meat for that matter, but I guess that started to make a little bit of a difference too, dropping the red meat, and then I don't really drink much anyway, so that really wasn't much of a difference. But just doing that alone and dropping the poultry intake a little bit did help to, lower it to a, bit of an extent there.
This is a great opportunity for this amazing man to let us do this, because he's the average bear. Now, hold on. He's the average bear when you look at a hemoglobin hematocrit. But if you look at the gene studies, I told you I would explain
Doc,
this.
if you just call me small, just tell me right now, man.
Right. I'm not calling you small. I'm not calling him small. All right. So, but do you want to overload iron levels into your brain, your heart, and to your liver, and you don't want it silently? I can tell you that. So now back to the genes real quick as we wrap up here. Thank you so much, Zach. So he's 1%, right? So 1% that he's a homozygote presenter where without androgens, you would never see this. And Dr. Election told me this. I've worked with Dr. Election for years. He said, Tom, with most of your guys, the 10% guys, you may be 10%, sir, listening to me right now, you may be 10% have genes for hereditary hemochromatosis that are heterozygote. You see, they're not fully expressed. He has a rare double homozygote presentation that when it's under the gas of even a little androgen, it's going to affect it, because we saw it. And that for me brought attention to it, and here we are. I never would have known it, because so many guys, if you look at his hematocrit, it's perfect. His average hematocrit's under 50%. He piped up a little bit from the Deca, and then it alerted me to look at the iron studies. And so how many guys are out there? Are you a 1%er, or are you, again, a 1%er that has elevated ferritin? I've done videos on that. That's the other guy. That's the guy with 1,700 ferritin. I know you've seen him.
Yeah,
right?
That's crazy, man.
That's the other guy. So you're not him, but you guys have similar genes. Just don't run the 23andMe. Run the real hereditary hemochromatosis gene. Run your CBC. Run your hematocrit. Look at your ferritin. Look at your iron studies. Get on the Anabolic Doc app, guys. I'm giving all the information here just 24/7, and see your caregivers, your healthcare. And if you don't understand it, go to a hematologist. What do you have to say in closing?
I would have to say that it's important to look at everything as, the body is a system, it's a unit, right? So in knowing that, looking at things in isolation, certain isolated values are important. Like, knowing your hematocrit by itself, that's important, but it's a lot more valuable when you look at it in coherence with something like, in my case, percent saturation. Because again, if you didn't look at it like that, but you knew to do that, then I wouldn't have seen Dr. Election. I would have, could have potentially been in more trouble later on years down the line. So look at everything as a unit, see trends as a pattern, look for patterns, and then take it from there.
And I'll tell you this: the most recent saturation, you're down into the upper 60s and 70s right there. So he went down, and we could use phlebotomy. You know, I talked to Dr. Election about this.
Yeah.
He said, Tom, there's no data to really say that just running saturations like that with normal ferritin and the normal hemoglobin hematocrit, that it's going to hurt him. There's no data to prove it. Again, but we don't know.
Yeah.
So again, this would be a reason why I take care of an individual patient, and it's what's your appetite, sir? What's your appetite? So keep testosterone low. We could phlebotomize. I think with Zach, we're gonna check it as much as we do every 4 months or so.
Yeah.
Right, 4 to 6 months, and then at a certain point, Zach, we might just, we starve the guy to death, and completely plant-based is helping, but you're not completely. You can't lose any weight. You don't have sleep apnea, right? You're going to get older, though, so that's just something that as you get older, things get worse. But maybe we are going to phlebotomize you, brother. Maybe we're going to phlebotomize you to keep, because you could see the effects of that's phlebotomizing right there. Look at that right there.
Yeah, I mean, that's the only way to find out.
I
right?
mean, but for most guys, you can tank your ferritin, and then you're depleted. Guys, I'm telling you, this is single-handedly the most complex medical subspecialty of testosteronology, this hematological stuff. There's no question, because I do it 24/7, and I have to look at all these permutations and combinations and use my specialists. And you went. This guy's not lazy. He went. I said, Zach, I don't know.
As a scientist, it's my duty to.
But it was
look,
a lot
look
of
at
work.
the data,
You
so.
saw election twice.
Yeah.
Right. So he had to go to him. Right. He has insurance. He went to him, and then we got these data points. And you said you'd like to make this video. So
Yeah.
Thank you so much, man.
Of course. Thank you, Doc.
All right, guys. Zach, thank you so much, man. Please,
My
please
pleasure.
follow anything. Anyone you'd like to say to people who follow you or what you're doing?
Give me half a year.
Okay. So this is a great man, and I love to feature a great guy that's also an exercise physiology kind of a guy, right?
Hey, gotta live it and breathe it, not just study it.
I love it. Boom. And I want this guy to live forever. Thank you so much,
110.
guys. Give a lot of comments on this stuff. Let's see. Do you guys understand this? Have you checked this stuff? Do you really know what's going on? And get on the Anabolic Doc app for all my medical information. Thank you.